We will give a lecture on how I do it on right anterior thoracotomy mini-AVR. Then we will ask her some learning questions at the end of the session. Please, Diana, stage is yours.
Thank you very much, Professor Otter. It's a pleasure to be back again after COVID. I think everybody else feels the same. It's great to see you again. Dear chair, dear panelists, thank you very much. I would like to talk about the RAST, so right anterior small thoracotomy. So I have started about 20 years ago in the University Hospital at Zurich, where we have started the program. Back then, of course, I was a resident, but I have actually gone through all the stages together with my seniors before. So we had the learning curve, which has been between like 2005 and 2007. That has already been published in another paper. And you will have the opportunity to check out our outcomes from the past 10 years, which is going to be tomorrow morning. So now, here are my interests, which I have many, but I have a hate for conflicts, so I have no conflict of interest. To begin with, I would like to show you something about the literature of RAST, which is quite scarce because not many centers are specialized in this. We also in Switzerland are the only ones performing it. Of course, Matthias Glaube, I think you should know all of this, this distinguished surgeon who has reported in 2013 a nice paper, a propensity score matched study between RAST and conventional replacement. He matched 138 pairs, and he had very low in-hospital mortality, so beautiful results. And he could also show that RAST had less AFib, less transfusion, less ventilation, and hospital stay. Here another one, 2 years later. Here you have already almost 600 RAST patients with a really nice bypass time, short ICU stay, low hospital mortality, and low stroke rate. Here is another one from the States, who has also shown, comparing RAST, hemisternotomy and sternotomy, that RAST had shorter ventilation, hospital stay, stroke was comparable between the groups, which is very important because at the beginning, when this started, there was actually doubt about it, that stroke rate would be lower than for conventional sternotomy because of the retrograde perfusion. But if the professionals and specialists do it with a lot of experience, you have actually the same results, and even better for the patients, which you will see. Mortality has also been comparable in this group. And here, a quick group, which is actually not a surgical one, but this one actually shows, this is from the Czech Republic. It has shown that the cerebral microemboli in mini-sternotomy and mini-thoracotomy are actually comparable and was not even present in this study, which is, of course, very special. There was no stroke, no mortality, which is a very nice result. Of course, there is also in sternotomy stroke and mortality, but actually it's not more in the RAST, and that's the important thing. It is not inferior. So that's why back in 2005, we were so much convinced that we wanted to start this. And now we are actually very happy about it because we believe that this is the only remaining surgical competitor for the future TAVIs. Here you can see the first publication which we did about the numbers. We had also quite nice 30-day mortality, 1.3%, but you have to be aware that this one also includes our learning curve. So for that, the mortality is quite nice and low. We had 0% permanent stroke. We had very good MACE-free survival, 1 in 7 years, which was low, with 95%, and freedom from re-op also 98%. Very important, if you start with RAST, you have to have a correct patient selection. First of all, you actually have to include all patients which are scheduled for AVR. You have to screen them, whether they are eligible for RAST or not. And actually, we include them all, and actually those which are not eligible for TAVI, like the heart team, we do anyway as a RAST. So we don't do any hemisternotomy anymore. So the RAST is the standard procedure which we do. We exclude patients with unfavorable exterior anatomy. That is a pectus excavatum or a large scoliosis. Unfavorable interior anatomy, which is also very important. You need to know where the ascending aorta lies behind the sternum. Then, if you have presumed pleural adhesions, like previous lung surgery or radiation therapy, then you actually should forget about RAST. If you have also small aortic annuli, mostly when you have female patients who have actually a large BMI and have really small aortic annuli, we did have some bad experience with these patients, so we are quite critical about those. So if there is this constellation, we really think about it twice if we do RAST, or if we do hemisternotomy, or if we do TAVI, of course. Then very important also the grade of atherosclerosis of the ascending aorta, and actually the whole of the aorta, of course. If you have 3 or 4, then of course there is no way to do RAST. So here you can see every patient who is actually scheduled for some kind of aortic replacement, is it TAVI or surgical, we do a TAVI CT, and we do the 3 mentio, and there we have everything we need, so we can see the aorta, we can see the diameter, we can see the annulus, we can see the average, and then the location of the aorta and the aortic valve is actually the most important thing. Here you can see the CT, which is actually quite ideal. So I don't know if I can, probably not. Not really well, a little bit. So you can see that it's right behind the sternum. So when you think the line which you have to have a nice look on the aorta is like here. So that is actually an ideal patient for a RAST. Here you have another one. This one is on the left of the sternum, which is not advisable to perform RAST. And then the plaques, of course, calcifications in the aorta, in the pelvic aorta, and in the femoral arteries. Like here you can see in the ascending aorta, which is not ideal for RAST. I wouldn't do it. Here as well, a little bit further up, against where you actually have to clamp with the Chitwood clamp. Here you can also see the 3D, you can see a big plaque just above the sinotubular junction. So that is also not advisable. And here you can see the pelvic vessels, which look nice in this patient. So this is also as important as for TAVI. Our surgical setup. So the incision is performed in the second intercostal space, rarely in the third. So actually at the beginning when we started, back 2005, we did a couple in the third one, but we fastly realized that the second one is the ideal one. Then aortic clamping is performed also in the second intercostal space. Then CO2 insufflation, of course, in every mixed surgery is very important. We put in a trocar in the 5th and 6th intercostal space. You will see it later on the video. And femoral cannulation is on the right side when we do a cut down, or we perform it on both sides when we perform it percutaneously, which we actually started a couple of years ago, which is even nicer for the patients because then you have a decreased risk for seroma. So, and first of all, my first video shows you the femoral cannulation, the percutaneous one, which, as I said, has become our standard in the past couple of years. If you want to start minimally invasive surgery, then I really advise that you get very well trained in peripheral cannulation, because we had a couple of problems at the beginning. That was back in 2005. So it was quite depressing, because the very first patient that we did actually had a retrograde aortic dissection. So that was one of the few mortalities which we had. So I can advise it everybody. So before you go and do this, you have to be really good at peripheral cannulation. So here we did the puncture of the vein first, of course. Oh, sorry, this is the aorta. So that's the arterial cannulation. It's all in cell linear technique. At our university hospital, of course, we were quite well trained, because we were or we still are, I'm not working there anymore, but they still do a lot of ECMOs. So that also helps gaining the expertise. We, of course, use the ProGlide on a daily basis, always twice for the artery. Just a quick question in between you. Who does minimally invasive surgery? Any of you? Nobody? You do, right? Professor Otter does, but nobody else in here. Really? 1, 2, 3? Wow, that's not a lot. Is it mitral? Mitral? Who does the mitral? 2, 3?
Some people from our panelists do as well. Perhaps they missed your question.
And aortic as well, but not RAST. Who does RAST? Nobody. But then mitral is good, because then you also do the peripheral cannulation, so you need to be trained in it well. So that's the second ProGlide which we put in. Back then, of course, 2005, we didn't have any ProGlides, so we did it always with a cut down until 2012. So from then on, we started with the ProGlides. Then it depended, of course, who was department chief, who actually liked the ProGlide or liked peripheral cannulation or not. So ultimately, also the surgeon decided. Here we put in usually 18 or 19 French. Arterial cannula. And that's, of course, the first thing you do. So some of my colleagues prefer to do this at the very beginning and then go on pump and then already open the chest. I like to save heart-lung machine time. So I usually just prepare everything on the thorax, and afterwards I do the cannulation, and then I really go on pump when everything is set. And that, of course, requires that you have 2-lung ventilation. So that's no big deal for the anesthetist, so when you tell them, they actually do it. On the other side now, on the left side, we do the venous cannulation. Then we do it with a long wire. Here we have the TEE, where you can see that the wire is already in the superior vena cava. That's where it, of course, should be. We usually have the anesthetists doing it. The echo, they're very well trained. So here's the lung cannula put in already. Very important to put it actually into the superior vena cava. Then you have the best drainage. And that's what it looks. So it's quite clean. And the risk of seroma here is actually 0. So we didn't have any. With the cut down, of course, you have a risk. So, and now we come to the main theme. We're going to be a little bit late because the first ones were late too. So here you can see the chest from the side of the surgeon. So you can see the right mamilla. So we always go through the second intercostal space. As I already told you, at the beginning we actually experimented a little bit around. So we tried the second, tried the third. We did a lot of CTs in the very first patients with 3Ds and reconstruction, which is actually the best incision site. But ultimately we find out it's actually the second one. So we just actually get through it. Even in obese patients, it is no problem to get through, even in women with breasts actually, but you also have to take care to drape the breast accordingly. So you must help, usually the scrub nurse, so they know what to do, a little bit to flatten down the breast. This is the first video we put in already a drain, and there through we actually put in the CO2 insufflation into the thorax. The question also comes always, what about the memory? So at the beginning we were proud not to damage the memory, not to dissect it, but of course it also depends on the surgeon. We actually abandoned the salvage of the memory, so we usually actually dissect it. This is already the left ventricular vent, which we put in. It's usually a small one. There you can see below, let's see if I can do it again. Right here, this is actually usually not always there because this is just for the video. So that's the camera, which you will see. And this is where we clamp, the chitwood clamp, intercostal space, also second one. And that is very, very important moment because here you can also kill the patient, as you surely know. The clamping you can actually get in the left atrial auricle, and then when that one is injured, of course, then you have to convert the patient. Usually, we had in the learning curve two, but they all made it. But we had to do sternotomy. So this endo camera shot, which you just saw, I stole from my mitral video. Maybe you ask yourself why there was already a aortic root in. Now we put in the cardioplegia up here, right? We usually do it with a long needle. This is from the mitral video, as you can see. This is aortic root cannula. We always put in Brettschneider between 1.5 and 2 liters. Then we do the aortotomy. This is just from the endo video. At the beginning it's not such a good quality, but here is the aorta. You will see later the valve inside. And you will also see some shots from the surgeon. That's what it looks like. Unfortunately, we don't have a head camera, but that's what the surgeon sees the valve like. So it's actually really, if you have on the CT what I told you, the right anatomy, then the surgeon can see the valve like that. Then it's actually easy play. You cut it out and you do whatever you do. Of course, the learning curve also includes the special instruments which you use for minimal invasive surgery. I was kind of growing up with those, so I have to say that I've never liked the let's say, normal sternotomy used instruments, because I never got used to those. I always prefer, even when I do like sternotomy or hemisternotomy, I prefer the minimal invasive instruments. For me personally, I think it's more physiological than the conventional instruments. So here you can see it's been nicely debrided. And now, of course, sometimes, this is the sizing, of course, the most difficult stitches are usually the ones on the right sinus. Now you can see this is also the first one which we always do. So there you have to make, this very special ice pick needle form, which always the scrub nurses are quite reluctant to learn, and some of them just can never learn it, even after many years. And that's the first one we usually do. And when this one is done, then it's actually easy. Usually the non-coronary and the left coronary you see without any problems. If you have problems to see the valve, sometimes it can be very, also in mitral surgery, very helpful to ask the anesthetist to insufflate the left lung, because that brings, of course, the heart a little bit to the right. So that has already helped me many times. And then the next question comes. Who uses core knots? Anyone using core knots? You know what that is? 1? Yes? Anyone else? 2, 3? Right? 4? Okay. So of course it's a financial issue, I guess. So back in the public hospital, we were also quite reserved about it. We really just used it in mini-mitral surgery, and it saves a lot of time. Even in the aortic. At the beginning, I must say, I always used it in mitral, and I was afraid about the aortic annulus and the aorta. But my colleagues did it already for years, and they said, come on. They didn't see any complications about that, so I actually trusted them. And I did it too. And I haven't seen any complications with that as well. So even if they're just really very, very near the annulus and also the aorta, so of course when you oversize, then probably you have to take care a little bit, but I haven't seen any complications with it. And that saves a lot of time, so we used to do it, of course, with the knot pusher device, which takes quite many more minutes longer. And that's also the cross-clamp time which can be saved. That's it. And usually also you can check the coronaries. You can usually see them quite well, like the left one always. The right one, of course, you have to check out with the instrument. So if you're interested in the outcomes, tomorrow, I think around 10 o'clock, I will have my presentation about our outcomes between 2013 and 2022. So sometimes here you can see the surgeon's fingers, so that's not me, that's my colleague. He has long fingers, so he can actually tie the knots and the aorta, that's no problem. And sometimes we really have patients whose aortas are just right behind the sternum, so that's quite near. If they don't have a big thorax, then it's actually no problem. So CO2, very important, of course. And then the de-airing, always, because you cannot de-air any other way, just with the LV vent, which you have in, and the CO2. who of you has a mini standardized minimal invasive program? Like a real MIC program. Anyone? You have a minimal invasive program, standardized, right? Yeah, 1, 2, so not many, right? So there we saw the de-airing also. Very important as well. Now we put on the ventricular pacing wire before we declimb, of course, because otherwise we have no chance to get to the heart, because we cannot see it through the small incision. Now the clamp is reopened, and that was it. The vent. Here we usually need to use the knot pusher, of course. That's the atrial pacing wires, which we always put on as well. And then we also close the pericardium with 2 or 3 stitches. This is actually a very nice soft tissue retractor. I don't know if you know it or have seen it. It's much easier than the one which I actually stitch on the patient with the sticker. It holds much better, and it also seals the whole operative field from the skin, which I believe is very important. So that's where we put through the atrial and the ventricular wires through the skin, the temporary wires. The drain is already in. Then, which is very important in any kind of minimally invasive surgery, is meticulous hemostasis. When I was a resident, I remember we had one surgeon who was an excellent surgeon, still is, but he actually hated to do hemostasis, and he just loved doing the valve stuff, and the rest he hated. So he actually did it like, yeah, come on, let's do it, and let's go home. And he had a really, really high rate of rethoracotomy because of that, which I believe is very sad. So a couple of minutes to be sure, because any kind of very small arteriola from the muscle can cause rethoracotomy, massive hemothorax, really small. Artery, you usually cannot even see it at this time when the patient has some noradrenaline. Of course, everything is vasospastic, so usually it starts bleeding when the patient goes to the ICU. So I personally, I use the electrocauter quite a lot, and I must say I don't have a lot of incidents of wound infection, neither mix nor sternotomy, but I have actually no bleeding. So that's what it looks like. It's usually like, I don't know, 6 centimeters, and yeah, it's one of my favorite surgeries. Okay, so let's go quickly to the take-home message. As I already talked about the learning curve, it should be step by step to avoid complications. There are known complications which can be avoided when you know about them, and when you had some proctoring, and when you just take care of the different steps. First of all, I would actually recommend to visit specialized centers to see and to learn and to talk to specialists. Then invite the proctor for the first cases when you have decided you want to do a program of your own. And then, as I said, gain experience in femoral cannulation. For the surgeon, Kate adds the pre-op planning. We've talked about it. Very important, the patient selection is actually crucial. Then specialize in the mix and the meticulous hemostasis we have talked about. For the patients, of course, the advantages are faster recovery, shorter lengths of stay, less pain, ventilation, great cosmesis, less blood loss, less blood transfusion. There are also some literature available about this topic, which is also very important. Less blood loss, transfusion automatically translates into better outcomes. We know that. Then, of course, reduced risk for deep wound infection, or actually no deep wound infection at all, especially not concerning the sternum or mediastinum. It's an attractive approach for also young and also for the elderly patients. It is a true competitor for interventional therapies, I believe. So, it is not widely performed worldwide, the RAST, because there's some things which you have to know and you have to gain experience and be capable to do it. As I said, we're the only ones in Switzerland, which is actually sad, but that's how it is. RAST has excellent short and long-term outcomes in the literature. It has low morbidity, low mortality. It is non-inferior to sternotomy and mini-sternotomy, especially when it comes to mortality and stroke. It is, and it will be, I think, the only true competitor for TAVI in the future, so I can just recommend that you start with it. Thank you very much for your attention.
Thank you, Diana, for your excellent and very clear-cut lecture. And we have learned a lot. If you put your headset on, is it with you? Yeah. So that my friends can ask questions in Turkish